All right. So welcome once again. And we were doing lung cancer last time. So we will start from where we left. All right. So I'll share the screen with you and then we will start with the lecture. So I hope you can see the screen. Please say yes if you can see it.
Yes, doctor.
All right, thank you very much. So today we are going to start with the treatment of lung cancer. Last time we completed the staging of lung cancer, or to be more precise, we were doing non-small cell lung cancer. And as you saw that the staging was quite complicated, but you do not have to memorize all that was there in the staging, and you can keep that for your reference. So last time we stopped here on this slide, we did not do screening. After screening, we'll go on to treatment. So screening is important in certain cases or in people who are high risk and who are old. So for those who have a 30-pack year smoking history and either continue to smoke or have quit smoking in the past 15 years. So as we discussed earlier, the most important risk factor for lung cancer is smoking. And here is a new term for you, which says a pack year. So 30 pack years. So what is a pack year? A pack year is that a person who smokes 20 cigarettes every day for 1 year. So he would have smoked for 1 pack year, right? So as I have written, 1 pack year is smoking 20 cigarettes a day for 1 year. If someone has smoked 10 cigarettes a day for 6 years, then he will have 3 pack years, because 1 pack year is 20 cigarettes. If someone has smoked 10 cigarettes for 2 years, then he will have 1 pack year. Okay, so I hope you got this point. So the guidelines from American Cancer Society, ACCP, NCC, and they're all different types of cancer and chest societies. They recommend offering annual screening with low-dose computed tomography scanning to patients aged 55 to 74 years who have smoked 30 pack years of cigarettes, all right? The Preventive Task Force extends the recommended age to 80 years. I don't know how much that matters. And the NCCN extends the age to 77 years. So basically, you start screening if the patient has 30 pack year of smoking. You start screening at 55 years, all right? Now, let us go on to the treatment, and as usual, I'll give you the drug list, and I'm giving you the list of all the drugs that are used in non-small cell cancer treatment. And these are a lot of drugs. As you can see, we have got anti-neoplastic drugs, carboplatin, cisplatin, cyclophosphamide, and cisplatin is very important. Vinorelbine, vincristine, they're also very important drugs. Paclitaxel and paclitaxel protein bound, which is also known as NAB paclitaxel, nanoparticle albumin bound paclitaxel, right? So you have to memorize the drug list, okay? Because I always ask questions from the drug list. I've already truncated this lecture. It is not the long version of the lecture, okay? Then we have anaplastic lymphoma cell kinase inhibitors. These drugs are known as molecular targeted therapies, right? They are used in very specific situations. For example, ALK1 is a gene. If there is any mutation in that gene, we will use this drug in that case, which means that we have to do genetic testing as well. So we do histologic testing, we do staging, and we do molecular genetic testing as well. And we have seen these drugs in the previous um, lecture as well in breast cancer, PD1 and PD ligand 1. This stands for programmed cell death receptor and ligand. So these are the drugs, nivolumab, pembrolizumab, atezolizumab, durvalumab, and cemiplimab, and ipilimumab. Okay, so unfortunately, pretty difficult, and you can mix up these drugs. There are lots of drugs, but try to memorize them. We have got EGFR inhibitors, MEK inhibitors, BRAF kinase inhibitors. These may sound like strange names to you, but that's how the genes are named, and that's how we look for the mutations in those genes. Then we have got tyrosine kinase inhibitors. All these drugs that end with an INIB or TINIB, they are tyrosine kinase inhibitors. RET kinase inhibitor, MET tyrosine kinase inhibitor, right? KRAS inhibitors, it doesn't end with a TINIB or INIB, okay? Then we have got monoclonal antibodies. Bevacizumab we have done previously as well. This is an vascular endothelial growth factor inhibitor, and these other drugs, okay? And because the cancer chemotherapy is emetogenic, it causes nausea, and it may cause severe vomiting, particularly those patients who are taking cisplatin. So we have got some antiemetic drugs which are used for vomiting, ondansetron, granisetron, and dolasetron. So all these drugs are used in cancer therapies, okay? So our treatment, discussion on treatment will include treatment approach and surgical treatment. Most of the times, you have seen in breast cancer as well, and you have seen, and you're going to see in lung cancer, and you will see in colorectal cancer as well, prostate cancer, that if the cancer is resectable, when it is in the initial stages, when the size of the tumor is not too big, or it has not spread to distant organs, or the local spread is not too wide, then we try to remove the cancer surgically, right? And with surgical therapy, we have got radiation therapy. We try to kill the cells, or sometimes when surgery is not possible, then we resort to radiation therapy. Okay, then combined with surgical treatment is radiation therapy and also systemic chemotherapy, which is usually given after, we call that adjuvant therapy, after surgery, to eradicate the residual cancer cells if there are any, okay? Then we have combined chemoradiation therapy, molecular targeted therapy. I've shown you so many drugs in the drug list, stage-based management, and I can tell you that in early stages, stage 1, stage 2, and until stage 3A, we can do surgery, okay? From stage 3B to stage 4, stage 4 is metastatic disease, then surgery becomes a bit difficult. And we will go to prevention and long-term monitoring of the patient, if time allows, okay? So treatment approach, stages 1 to 3A of non-small cell lung cancer, surgery is the treatment of choice. In addition, patients with resected lung cancer have high risk of relapse, so are treated with adjuvant chemotherapy. Now, relapse is very common in lung cancers. 80 to 85% of patients, even those who have undergone surgery, they relapse. And that's why the mortality rate is very high in lung cancers. Okay. Stage 3B and stage 4 non-small cell lung cancer, they are usually offered chemotherapy with option for surgery. Sometimes there are satellite lesions, small cancers that are separate from the primary tumor. We can resect them if they're in the brain or some other place in the body, okay? But basically in stage 3B and stage 4, we do not offer surgery. We do chemotherapy, and most of the times, in lung cancer, because as I said, 80 to 85% of cancer patients, even if they are stage 1 to stage 3A, they relapse, and eventually we have to give them palliative therapy. Palliative therapy is sort of symptomatic therapy, which is given to relieve the symptoms or the pain or any other complication of cancer, okay? We can also do palliative surgery. For example, if the size of the tumor is too big and it is pressing or compressing other organs or other structures, then we can do surgery to relieve the pressure, or if it's pressing upon a blood vessel that is compromising the blood flow to some organ. So we can do palliative surgery to relieve those complications or to give some relief to the patient. All right. Right. So after this slide, I'll take attendance. Molecular targeted therapy plays an increasingly important role in treatment of non-small cell lung cancer, and I've shown you so many drugs that are used in case of mutations of certain genes like epidermal growth factor receptor gene or ALK gene. Okay, so radiation is a reasonable option for treatment in patients who are not candidates. So every every tumor is not operable. In case there are some limitations or some contraindications to surgery, for example, if the lung function is compromised to such an extent that we cannot give anesthesia or we cannot remove lung tissue, then the only choice that we have or that we are left with is radiation therapy or chemotherapy. So role of adjuvant radiation therapy after resection of primary tumor remains controversial because many clinical trials have shown that they do not improve the overall survival of the patient. Because most non-small cell lung cancer cannot be cured with currently available therapeutic modalities, palliative care is an important part of the treatment, as I have already mentioned. All right. Now, I will pause the recording for a minute. Right. So, radiation therapy. Stage 1 and stage 2 non-small cell lung cancer radiation therapy alone is considered when surgical resection is not possible because of limited pulmonary reserve or presence of comorbidities, right? So maybe the lung function is already so much compromised that it is not possible to do surgery and remove the lung tissue, okay? Radiation therapy alone as local therapy in patients who are not surgical candidates has been associated with 5-year survival rates of 13 to 39% in early stage. So 13 to 39% survival for 5 years is low rate of survival. What this means is that even in stage 1 and stage 2, if you give radiation therapy, about 85 to, or you can say 60 to 85% of patients will die in 5 years. Only 13 to 39% will survive for 5 years, but how long they survive, we do not know, okay? Adjuvant radiation therapy, the role of adjuvant radiation therapy means the radiation that is given after the surgical operation or surgical intervention. Okay, after resection of primary tumor, it remains controversial because it has not been shown to improve overall survival. Now, this stereotactic body radiation therapy, this is not our subject. This is the subject of a radiation oncologist. So I've written for reference only. This, you can refer to it whenever you want, but this will not be included in the examination. So what you do in stereotactic radiotherapy is that you give a high dose of radiation, which is very, very focused on the tumor, okay? It is also known, sometimes it is known as cone down therapy, okay? So that's all you have to know about this. It is used to treat non-small cell lung cancer and also lung cancer. Okay, so and another important thing that you might want to know is that in this SBRT, the visits are reduced from 20 to 3 to 8 visits. Okay, if you're doing conventional radiotherapy, then the patient has to visit 20 to 33 times. So which means that those hospitals that have this equipment for stereotactic therapy, the patients has to visit only 3 to 8 times. Okay. Now we go on to systemic chemotherapy, which is our field. Uh, Now only 30 to 35% of patients with non-small cell lung cancer present with sufficiently localized disease at diagnosis for application of curative surgical resection. Right. So this means that about 70 or 65 to 70% of the patients, when they are diagnosed with non-small cell lung cancer, they cannot be operated upon, right? Only 30 to 35% present with sufficiently localized disease. So 65 to 70% of the patients, they cannot be operated upon because they are diagnosed at a late stage, or their lung function has decreased to such an extent that we cannot perform a surgery. Now, even out of these 30 to 35%, 50% of the patient are going to relapse. Okay, 50% of patients who undergo surgical resection experience local or systemic relapse. Okay, so that's why I said that 80 to 85% of patients who are diagnosed with lung cancer, they relapse sometime after their treatment, right? So it says 80% of all patients with lung cancer are considered for chemotherapy at some point during the course of the illness. And that is the reason that lung cancer has got the highest mortality rate among all cancers. The treatment of non-small cell lung cancer has drastically changed over the past few years with the advent of molecular targeted therapies, right? Now, these molecular targeted therapies are expensive, and they also require the analysis of genes, right? So there are certain kits available, but if you have that facility, then you can analyze those genes. They're not very difficult. They are sort of PCRs through which we can identify the mutations in those genes. So cytotoxic chemotherapy retains a role in the management. Chemotherapy alone has no role in potentially curative therapy. Curative therapy means the cancer is eradicated, which is in most of the cases not possible in lung cancers. Okay. Adjuvant chemotherapy, which means adjuvant always means the therapy that is given after the surgical procedure. So it has a survival benefit. It does not cure. It might increase the survival, might prolong the life. And how much will it prolong? Maybe a few months, okay? So before I go any further, I want to show you the protocol for lung cancer. You know, we have in this protocol, we have got two drugs, vinorelbine and cisplatin. As I said, cisplatin is very commonly used in lung cancer. And most of the time in the treatment, in pharmacological treatment of lung cancer, we have got doublet therapies. Like in this case, you see two drugs. Okay, and this is how we write the protocol. There are so many other protocols as well. So, but in this protocol, what it says is that, for example, vinorelbine, we will give vinorelbine on day 1 of the therapy of a cycle, or day 8 or day 15 of the cycle. And cisplatin, we give from day 1 to day 3, which means 1, 2, 3. Okay. What is the dose in milligram per meter square? Now, again, note that we are giving, or we are measuring the dose, not kilogram body weight per kilogram body weight. We are measuring per meter square, which measures the body surface area. Okay. So we give 25 milligram per meter square. It will be less if the body surface area is less, and if the person is very big, the body surface area is going to be more, so the dose will be more. Okay, how do we give it? We use the diluent, which is normal saline, 0.9%. How much in most of the IV cancer therapies, we use normal saline. How much of normal saline? We will use 100 ml for vinorelbine and 500 ml for cisplatin. And how do we give? How long should we take? We should give this 100 ml with vinorelbine in 10 minutes. But cisplatin, we should give over 1 hour, and both are given intravenously, right? There are some drugs that are given over about, say, many hours, over 22 hours, okay? Some are given over 2 to 3 hours, slow infusion, okay? So this is one way of writing a protocol. Here is another way. This shows the days, day 1, 2, 3, and this is day 29, okay? And what it is telling you is that on day 1, 2, and 3, we give cisplatin, like it's written over here, day 1, 2, 3. And vinorelbine, we give on day 1 and day 8 and day 15, right? So now after that, we do not give anything because the cycle is 28 days. Okay, so after day 15 until day 28 or day 29, here we will start a new cycle. So this is cycle number 1 and this is cycle number 2. And we can give 4 cycles, we can give 6 cycles, depends upon the oncologist. Now notice that we have not given anything from day 15 to day 29. The reason for not giving anything is because these drugs are so cytotoxic that they cause myelosuppression. They kill all the dividing cells. So we are giving time to those cells to recover. And what are dividing cells in the body? They are hair follicles. So in cancer therapies, most of the times the hair fall off, okay? These are bone marrow cells, the red blood cells, the white blood cells. They are rapidly dividing cells. And when we give these therapies, those cells will also be, they will be killed, okay? So the person might get anemia, or he might get neutropenia. He might be predisposed to infections, right? So that is why we are giving a gap in treatment from 15 to 29 days for the bone marrow, particularly the bone marrow, to recover, all right? Now, repetition is day 29. So one cycle is 28 days. Sometimes the cycles are 21 days. It depends upon the cancer and the treatment protocol. Now, we can give 4 to 6 cycles. And we also note that vinorelbine is to be rapidly administered intravenously, that is over 10 minutes. We give 100 ml over 10 minutes. But we are also writing in our protocol that there could be a danger of thrombophlebitis, danger of necrosis after extravasation. Extravasation means that the drug has come out of the vein, right? It is damaging the tissues. These are toxic drugs. And when they come out of the veins in which they are infused, they cause severe damage and necrosis of the tissue. So to avoid that, we use something which is known as Port A catheter, okay? And after we have given this 100 ml, we follow this up with 250 ml of 0.9% normal saline, okay, which is given intravenously. So we have given this drug. Now we want this drug to be eliminated from the body because it is toxic. It causes peripheral neuropathy. It damages the microtubules. So we want to get it out of the body. And similarly, cisplatin is also a very toxic drug. It damages the kidneys and it damages the neurons as well. So cisplatin we give only when the GFR means that the kidney function, glomerular filtration rate, it is more than 60 ml per minute. Less than 60 ml per minute, we do not give it. That means that the renal function is insufficient, okay? And this is also a nephrotoxic drug. So when we give cisplatin, we give a pre-medication 250 ml of mannitol. And if you remember, mannitol is an osmotic diuretic. Or with this, we give 40 milligrams, and we are giving this before the infusion, right? Before cisplatin infusion, 500 ml. So we also give 40 milligram of furosemide, which is a loop diuretic. Again, our purpose is to infuse the drug, have the effect of the drug and then try to eliminate the drug from the body. So we also give a post medication. Pre-medication is 250 ml of mannitol, and post medication is 1 liter of normal saline intravenously. So this is how we write our protocols, okay? And I have given you a reference in which you can, there are many protocols for lung cancer, and I've given you a link, a URL, where you will find all the protocols for lung cancer. Now, I mentioned that there is a risk of thrombophlebitis or tissue necrosis if there is extravasation of the drug. Extravasation means the drug has leaked out of the veins. So we use a port A catheter. What is a port A catheter? You know, this is the catheter we implant it under the skin, right? And this catheter is going into the left subclavian, this is the right subclavian vein. Okay, so this is known as a central line. A subclavian vein is a big vein. If you infuse an anti-cancer drug in a big vein, the chances of extravasation are very low. And you see the catheter, if you look closely, the catheter is going up to this superior vena cava from this right subclavian vein into the superior vena cava, and that is where we release the drug, okay? And you see this is a port A catheter which is implanted under the skin, and this is our infusion. So we just insert the needle into this catheter, right? So where it is implanted under the skin, you know, we have to give 6 to 8 cycles, so it becomes much easier for us to give the drug. And this is how it will appear on an X-ray, okay? Right, so let's go on to chemotherapy. Chemotherapy may be considered a part of multimodality therapy. Multimodality means we are using many treatment modalities like surgery, radiation therapy, and chemotherapy. They are all different treatment modalities. Chemotherapy is used alone in palliative therapy for stage 3B and stage 4 cancers. And also when there is malignant pleural effusion in stage 3B. Patients with good performance status are good candidates. Now, what is performance status? I've given you over here. It basically means the daily activities of a person, how much of daily activities a person can perform or is performing while he's taking the treatment. So we have got 2 or 3. There is a Zubrod scale and Karnofsky scale. We also have an ECOG performance scale, okay? So they're more or less the same. If the person has normal activities, that means it's all right. This scale is 0 or 90 to 100%. If there is no significant decrease in daily activities, which means that he cannot do strenuous activities, but he can perform normal activities, no problem at all. Then we call it scale 1 or 70 to 80% in this and so on. He is in bed or chair less than 50% of waking hours. When he's awake, then it is grade 2. If he stays in bed or in chair for more than 50%, then it is close to stage 3 or grade 3. And if he's bedridden, then it is grade 4, okay, or 10 to 20% of Karnofsky's. So this is an important criterion for guiding our therapy, or also for predicting the prognosis of the treatment, okay? If the level of activity goes down with treatment, that is not a good sign. So non-small cell lung cancer is only moderately sensitive to chemotherapy. Again, bad news, with single agent response rates in the range of 15%. So usually we don't give monotherapy, we don't give a single agent, we give a doublet therapy, or to that we can even add molecular targeted therapies. Now we have got newer agents. They are not new actually. Gemcitabine, pemetrexed, docetaxel, vinorelbine. They have promising single agent activity with a response rate of 20 to 25%. Now, again, you see 20 to 25% means in about 75 to 80%, the response will not be good. But anyway, it's better. Lung cancer is not a very good cancer that does not respond to the therapies. Now we have got combination therapies, platinum based. Cisplatin has been the cornerstone of most combination regimen. It is, I'll show you, there are many regimen, chemotherapeutic regimen that have cisplatin in them, okay? And randomized controlled trials have failed to show a clear superiority of one platinum containing compound over the other. But we use cisplatin. You know, we have carboplatin, we have got oxaliplatin, they are all platinum compounds. But most commonly it is cisplatin, although it says that the others are equally effective, but cisplatin is most commonly used. So this ECOG trial, this is a cancer society. See the combinations, we have doublet therapy, cisplatin, gemcitabine, cisplatin, paclitaxel, cisplatin, docetaxel, and we also have carboplatin, paclitaxel. Okay, so they all have similar overall response rates. And as I mentioned previously, in October 2012, FDA approved protein-bound paclitaxel. This is also known as nanoparticle albumin-bound paclitaxel. Okay, this was actually approved a long time before 2012, but for non-small cell lung cancer, it was approved in 2012. Okay, and it is given in combination with carboplatin, which is written over there. Right, and these are the protocols for various stages. I've given you an example of 1B or 2 non-small cell lung cancer, and there are many of these. Okay, cisplatin, vinorelbine, cisplatin, vinblastine, cisplatin, etoposide. Okay, so if you go to this website, you will get all protocols for all stages of lung cancer. Now that's how we treat. You know, we first diagnose the lung cancer. We determine the stage of not only lung cancer, any cancer, but particularly in lung cancer, we do the histology as well, and we do we look for gene mutations as well, okay, for targeted therapies. Now, complications of chemotherapy, it can give rise to many complications. Okay, I've given you a detail of complications in a table in this slide, but febrile neutropenia or bleeding could happen, and renal failure, ototoxicity from cisplatin, and as a result of renal failure, we can get further complications like hyponatremia and hypomagnesemia, and we can get peripheral neuropathy, cisplatin, paclitaxel, vinorelbine. We have discussed this in the previous lecture as well. All right. Now we go on to combined chemoradiation therapy. The current standard of care for good risk. What is good risk? Which is Karnofsky performance score of 70 to 100, or you can have ECOG performance score, or and Zubrod that I mentioned in the previous slide. Okay, weight loss. You know, weight loss is not a good sign in any cancer, and particularly in lung cancer. So good risk patient who has got good performance, minimal weight loss, and the disease is locally, I mean, it is unresectable. The cancer is advanced, but the other signs are good. So in these cases, when the cancer is unresectable, which means we cannot perform surgery on this cancer, then we give chemoradiation therapy. And recommendation is all the ones that I have shown you previously. Cisplatin combined with vinorelbine or etoposide, and then it is also combined with radiation. Okay, and look at the survival advantage: 17 months versus 14.6 months, which is about 2.5 months survival. Okay, so not very good news, but still there is a little bit of survival advantage. And again, chemotherapy regimen are cisplatin, vinblastine, or etoposide, and many others. Okay, consolidation therapy is sort of maintenance therapy. We give initial therapy, right, to induce a remission, right? Then after that, we give consolidation therapy, which means That is a sort of a maintenance therapy. So again, it is cisplatin etoposide over here. And median survival with this combination is about 26 months, which is 2 years and 2 months. Okay. Now, molecular targeted therapies in recent years, increased understanding of molecular abnormalities in lung cancer and development of molecular targeted therapies have produced a paradigm shift, which means we have got new ways, a new way of treating lung cancer. Molecular testing in non-small cell lung cancer has become more common if you have the facilities to find a mutation that is susceptible to molecular therapy. And I'll give you examples of those mutations. And it also depends upon the histologic subtype, right? So first we do the histology, and then we do the molecular testing or mutation testing, okay? Mutation testing should include genes which are EGFR, epidermal growth factor receptor, KRAS, very commonly mutated gene, particularly in colorectal cancer. This gene is mutated in a lot of types. We are going to do colorectal cancer in the next lecture, okay? Then this lymphoma kinase, ALK gene, ROS, PDL1, you know, we do, it is preferable depending upon the histological type to do this gene testing, but this is basically the job of the pathologist, okay? And the results will determine the eligibility for treatment. For example, if we find EGFR mutations, which are given over here, then this osimertinib is our drug of choice. We have other drugs, gefitinib and erlotinib, afatinib, and dacomitinib, but if we find EGFR mutations, then we more commonly use osimertinib, okay? If it is an ALK mutation, anaplastic lymphoma kinase, then we give these inhibitors, crizotinib, ceritinib, alectinib, and brigatinib, and lorlatinib, okay? Difficult names, you know, people often get confused, but at this stage, you have to memorize them, okay? Maybe you'll forget them later on, but you will have to memorize them now. These patients do not benefit from treatment with EGFR directed therapy. So if a person has ALK rearrangement, then he will not benefit from other drugs. He will benefit only for the drugs that are used for ALK gene mutations, okay? And for other targeted therapies, you know, these are all targeted therapies that I've given you over here, starting from here, you know, so you can refer to the drug list. Right. Immunotherapy. Now, immunotherapy, all these monoclonal antibodies, they are immunotherapies, okay? Even this PD-1, this is also, you know, these are monoclonal antibodies. So these are immunotherapy, immune system or antibodies, monoclonal antibodies are being used for treatment. Immune-related adverse effects are a common complication of checkpoint inhibitor, right? And checkpoint inhibitor genes are given over here, important. We saw them in breast cancer as well. Nivolumab and pembrolizumab, atezolizumab, okay? Ipilimumab, okay? Semiplimumab, sometimes difficult to pronounce. Right. Okay, so up to 40% of the patient, we get adverse effects. And what are the adverse effects? They could be dermatologic, which means skin, pulmonary, gastrointestinal, endocrine, neurologic, cardiovascular, musculoskeletal, lots of adverse effect. I've given them in a table over here, but the treatment depends on its severity. And because these are immune mediated, we give corticosteroid therapy, okay? And these are all the complications that we can get, but these are the major or broadly speaking, these are the complications over here. You can keep this for your reference, all right, when you go to your grades. Now, there is one more thing that I must explain to you, which are grades of toxicity, right? And we have to know them because cancer drugs are so toxic, you know, they have a very narrow therapeutic index and they cause a lot of toxicities. So grades refer to the severity of the adverse effects. AE stands for adverse effects. So this common terminology criteria for adverse effects, it displays grade 1 through grade 5 with unique clinical descriptions. You have to know this all from exam point of view. Okay, grade 1, it is mild, almost asymptomatic, no problem. Clinical or diagnostic observations only, no intervention is indicated in grade 1. It is so mild. The patient doesn't have any problem, maybe a small skin rash or something like that. Grade 2 is moderate, okay? And non-invasive intervention is indicated, local or non-invasive, okay? Again, it is not a big problem. Limiting age-appropriate activities of daily living, right? So if the person is very old, maybe his activities might be affected more than younger people, but grade 2 is moderate. Grade 3 is severe, okay? But it is not immediately life-threatening. And you have to hospitalize the patient, okay? Or if the patient is already admitted to the hospital, you have to prolong the hospitalization, okay? You have to keep him in the hospital for a longer duration. So it is disabling. Then grade 4 is life-threatening. It is an emergency. You have to intervene very urgently, okay? And grade 5 means that the person has died. It is the most severe form. So these were the grades of toxicity. Next is stage-based management, and we will take a break after 5 minutes, okay? So stage-based management, stage 1A, 1B, I've given you these different combinations in which you can get these stages. You don't have to memorize them. You only have to memorize stage 1 or stage B. Surgery is the treatment of choice. But before we do surgery, we have to do a careful assessment of residual pulmonary reserve, okay? So we have to exactly find out how much of the tissue we have to remove the lung tissue, okay? So it could be a lobectomy, segmental or wedge resection of the lungs. A certain part of the lung is resected, it is cut off, and it is sent to the pathologist for further examination. The risk of local recurrence is higher with limited resection. So that is a problem, you know. If we remove too little tissue, there is a risk that the cancer will be left behind in the lungs. If we remove too much of lung tissue, then the lung function will decrease, okay? So that is a problem. VATS stands for video-assisted thoracic surgery. It could be used, you know, if the facilities are there. Patients with insufficient pulmonary reserve may be treated with radiation therapy alone or with curative intent, but we have seen that it is not a very successful way of treating. Adjuvant cisplatin-based therapy improves survival in resected stage 1A and 1B and even stage 3A. Okay, so again, we have seen all these cisplatin-based therapies, the doublets, combinations with paclitaxel or vinorelbine or etoposide. We can use carboplatin, we can use protein-bound paclitaxel. So we have a lot of choice, okay? So many drugs. I've shown you all in the drug list. Now, stage 2B. Again, I've just to remind you, I've given you the tumor sizes. T1 is less than 3 centimeter. T2 is greater than 3 centimeter, but less than or equal to 5 centimeter, right? And here you see N is 0 in T2B, but in stage 2A and 2B, most of the times, there is a lymph node involvement, okay? N1 means one lymph node is involved, okay? Here T2, the tumor size is increased and one lymph, so it will be 2B, okay? But anyway, you just have to remember 2A and 2B, not all these things. That is for your reference, and I've given it to you in the previous slides. So surgical resection is the treatment of choice. Long-term survival is 10 to 25%, very low, okay? Patients with resected stage 2 disease are candidates for platinum-based adjuvant chemotherapy. They should be offered cycles of platinum-based adjuvant therapy plus osimertinib. Now, this drug is given when you have an EGFR, epidermal growth factor receptor mutation at a particular place. Okay, so again, platinum-based chemotherapy, and a cone down boost, which is radiation, which is focused on the tumor tissue. You know, if you give radiation to normal tissues, there are side effects of the radiation, and radiation can even cause a normal cell to become a cancer cell. So we try to have very focused and limited area of radiation. That is why, you know, it is a specialty. There is a radiation oncologist who is specialized in giving radiations. Now, stage 3A, it is controversial. Surgical resection, chemotherapy, radiotherapy, or a combination, any of these. You know, so different hospitals, different oncologists, different surgeons will have different approaches. That is what we call a controversial approach. Overall 5-year survival rate is 10 to 15%, very low, which means after 5 years, about 90% of the patients will die. Resectability rates are again low in stage 3. You know, the tumor size is pretty big. Tumor is more than 5 centimeter. T4 is more than 7 centimeter. Okay, so we have T4 as well. So resectability or operability, okay, that is very low. The cancer is not always surgically treatable, right? A cone boost again may be useful, which is radiation. Stage 3B, we have said that stage 3B and stage 4, they are not resectable cancers, okay? So it's time for a break. So please take a break, and when we come back, remind me to start the recording once again. I'm stopping, or I'll pause the recording for the time being, okay? So stage 3B, non-small cell lung cancer, and we said that it is not resectable. We cannot operate upon this patient. Patients with satellite lesions, you know, T4, the tumor size is more than 7 centimeter. Satellite lesions are cancers which are separated from the primary tumor, or which are not continuous with the primary tumor. So it is only the satellite lesions which might undergo a surgical resection if possible, followed by adjuvant chemotherapy. All other patients with stage 2B are not candidates for surgical resection. These patients are best managed with chemotherapy, combined chemoradiation therapy, or radiation therapy alone, depending on the extent of the disease sites, or extent of the disease or sites of involvement. You know, sites of involvement, we have seen in staging that the pleura could be involved, or the both layers of the pleura could be involved. Pericardium could be involved. Trachea could be involved. Diaphragm could be involved, okay? Or hilar regions could be involved. So it depends which regions are involved over there. So by now you must have understood two things. Number one, that from stage 1 to stage 3A, we perform surgeries followed by radiation therapy or chemotherapy. Or if the cancer is not resectable in these early stages, then we can give chemoradiotherapy, radiation therapy combined with chemotherapy. Now, which chemotherapy? I've given you a long list of drugs, right? So we have to choose. Most of the times we choose a doublet therapy. Most commonly in chemotherapy, we combine cisplatin with some other drug like paclitaxel or docetaxel, or with etoposide or gemcitabine. You know, so many other drugs are there, or we could add to this therapy the molecular targeted therapies. Oh my God, what has happened over here? All right, we could add molecular targeted therapies, of which I've shown you so many in the drug list, okay? So stage 3B and stage 4, these people are not good candidates for surgery. what will we give them? We will give them chemotherapy. And one more thing that you must understand about lung cancer is that lung cancer is the deadliest cancer. In 80 to 85% of the patients, the disease recurs, it comes back, whether we do surgery or we give chemotherapy. The time of remission is not very long, and even the survival advantage is not very long. Okay, we get a survival advantage of a few months only. So those are the basic things that you should understand in lung cancer. Patients who have malignant pleural effusion are not candidates for radiation therapy, right? In what happens in pleural effusion, there is accumulation of fluid in the pleural spaces, and most likely the lung has collapsed. Okay, they are treated as stage 4 cancers, and they are given palliation therapy. Now, also the patients with poor performance status are not good candidates for chemotherapy or combined modality therapy. So again, we have to give them palliative therapy. Right, stage 4 is distant metastasis. It could be a metastasis to one organ, or it could be metastasis to more than one organ. If it's one organ, we call it M1A, or if it is more than one organ, then we call it M1B, okay, or M2B, whatever it is. So patients with solitary brain lesions, now it has gone to other organs, we can do surgical resection of the metastatic, if it's of the metastatic disease, okay? If it is in the brain, we can do a stereotactic radiosurgery, okay? That is the specialty of the radiologist. If it is an adrenal mass, we can resect that mass, but still we have to give chemotherapy or palliative therapy. A first-line therapy, again, it is cisplatin based, and it improves survival. It does not cure the disease. It is very rare that we cure the disease in lung cancer. Patients older than 70 years or those with contraindications to cisplatin may be treated with carboplatin, but carboplatin also has its own side effects, okay? Patients with non-squamous histology, and you know that the most common histology in lung cancer is adenocarcinoma, absence of cranial metastasis and no hemoptysis, may be candidates for bevacizumab. Now, bevacizumab is the drug that inhibits the formation of new blood vessels. And I've explained to you previously that the tumor grows very fast. It needs blood vessels. If it doesn't get blood vessels, the cancer cells will not get nutrition and they will start dying. So this is one of the ways in which we treat lung cancer, okay? So, but obviously because the blood vessels are not being formed, so there is a chance of bleeding. So there are certain contraindications over here, okay? Even in the brain, if there is bleeding in the brain, that is cranial hemorrhage, that is a very serious complication. So again, this is given in combination with carboplatin, paclitaxel, or cisplatin gemcitabine. And this is the last slide of the lecture, and this is also for your reference only. The patient must continue with his activities, and it is measured by many different scales, Zubrod or Karnofsky or ECOG performance scale. Patient should be encouraged to remain active during and after the treatment of lung cancer, and a declining activity level usually signifies progressive or recurrent disease, but also may be due to adverse effects of the treatment. So decreasing activity is not a good sign in lung cancer, okay? Prevention and long-term monitoring, for the moment, we will not do that because the lecture is already quite long. But if you want, I can give you the literature for that, okay? So that is all for lung cancer. If you have got any questions, you can ask me now before I take attendance. Okay, so that means I got no question. So what I'll do is that I'll stop recording over here, and I'll also stop sharing the screen, and then we will take 5 minutes to share the next lecture, which is colorectal cancer. Okay.